সঙ্গীত থেকে সাহিত্য, চলচ্চিত্র থেকে জনজীবনের প্রতিটি স্তরেই রয়েছে হৃদয় দেওয়া নেওয়ার কথা। হৃদয় নিয়ে এত কথা বলা হলেও আমরা কজনই বা হৃদয় অর্থাৎ হৃদযন্ত্রের সঠিক যত্ন নিই? বর্তমানে তীব্র ইঁদুর দৌড়ে সামিল মানুষ, তাই হৃদয়ের যত্নের কথা তার মনেই থাকে না। হৃদযন্ত্রের সঠিক পরিচর্যা শরীরের অন্যতম গুরুত্বপূর্ণ এই অঙ্গের সুস্থতা রক্ষা সহ হৃদযন্ত্রের সমস্যা সংক্রান্ত নানান বিষয়ে সুপরামর্শ দেওয়ার অন্যতম ঠিকানা কার্ডিওস্ফিয়ার নামে এই সংস্থাটি। দুর্গাপুরের সিটি সেন্টার কমার্শিয়াল মার্কেট স্থিত স্ক্যান এক্স নামক ডায়াগনস্টিক সেন্টারের সঙ্গে যৌথ উদ্যোগে পথ চলা শুরু করেছে কার্ডিওস্ফিয়ার। প্রখ্যাত হৃদরোগ বিশেষজ্ঞ ডাক্তার তুতান দাস ও ডাক্তার মণিদীপা মজুমদার হৃদরোগীদের নানান পরামর্শ প্রদান করে থাকেন। এই দুই চিকিৎসকের সহযোগিতায় হৃদযন্ত্রের সম্পূর্ণ চেক আপ, হৃদরোগ বা হার্ট অ্যাটাক, হার্ট ফেলিওর, হার্ট রিদমিক সংক্রান্ত সমস্যা ইত্যাদির সুচিকিৎসা করা হচ্ছে বলে জানান দুটি সংস্থারই কর্মকর্তারা। এখানে স্বল্প খরচে অ্যাঞ্জিওপ্লাস্টি, পেসমেকার, আইসিডি, সিআরটিএস, ভালভ সমস্যা ইত্যাদি সহ হৃদযন্ত্রের যাবতীয় সমস্যার সমাধান করা হয় বলে জানিয়েছেন ডক্টর তুতান দাস ও মণিদীপা মজুমদার।
Especially all our seniors, respected our colleagues and our friends, old and new, who took the time out in a rainy evening to be here with us for an academic discussion today evening. These topics are known to everyone, lipid management or treating diabetes. We will just go through them really quickly. But before I start with the academic discussions, I would also like to really formally introduce ourselves. We are very new to Durgapur. I am Dr. Monideepa Majumdar. I am a DM cardiologist, interventional cardiologist, consultant at Borivalian Hospital. And my friend and colleague here is Dr. Tutan Dash. He is an interventional cardiologist in Vivekananda Hospital, and he has been working here for more than 1 year. And we have been doing a lot of procedures, and in fact we have done a lot of new procedures in our respective hospitals, obviously including angiograms, angioplasties, pacemakers. Apart from that, cardiac resynchronization therapies, ICDs, as well as device closures in pediatric cardiac heart diseases like ASDs, balloon mitral valvotomies, which were not very commonly done, not in all the hospitals. And we are very excited to have been given a chance to speak today. Thanks to Sun Pharmaceutical for the opportunity, and thank you all for gracing us with your presence. We'll start with our first topic of today. High intensity statin in acute coronary syndrome, an update. I'll be also talking about use of statins in other situations as well. Burden of coronary artery disease in India. As we know, India being one of the major diabetic capitals of the world is also slowly becoming the capital of coronary artery diseases. And CAD is increasing most rapidly among patients less than 40 years of age, with 10 to 25% of myocardial infarctions in India occurring before the age of 40 years. More than 50% of CAD-associated deaths in India occur before the age of 50 years. And it is alarming patients with coronary artery disease. 79% of Indians have at least one lipid abnormality. We are highlighting here the other risk factors of CAD like sedentary lifestyle, obesity, hypertension, diabetes and smoking. Apart from that, of course, sleep disturbances, high stress environments, increased alcohol consumptions, all these things lead to higher chances of coronary artery disease. And this 79% of Indians that have at least one lipid abnormality, more than 50% are usually undiagnosed or undertreated. The commonest lipid abnormality that we see in India is low HDL-C, which does not really have a particular treatment. But the other two, that is hypertriglyceridemia, increase in triglycerides, and high LDL is also seen pretty commonly, and that needs to be treated depending on the clinical scenario of the patient. Statins reduce LDL-C and ASCVD risk effectively and safely. So we talk about ASCVD risk a lot, atherosclerotic cardiovascular diseases, which include ischemic stroke, acute coronary syndrome, including STEMI and STEMI and unstable angina. But we hardly ever calculate the ACVD risk. It is actually very easy to calculate. There are risk calculators, and in any high risk patients, if you got 2 minutes of extra time to sit with your patients, just open online on some online portal. ACVD risk calculation is extremely easy, and we can easily categorize patients into low risk, intermediate risk, moderate risk and high risk, and accordingly assign them to statin therapy. Numerous studies over the past 50 years have conclusively shown that abnormal lipid accounts for more than one half of CAD and nearly one half of cerebrovascular accidents, and that lipid lowering therapy with statin can reduce the risk by more than 50%. Larger absolute benefits would accrue with more prolonged statin therapy. That is true for any and all chronic diseases, as we all know. Longer duration of statin treatment was associated with greater reductions in CVD risk. There is this meta-analysis which was published in 2020, which showed that people who are on statin, it included around 148,000 patients involved in 58 clinical trials. It showed that there is with every 1 millimole per liter reduction of LDL-C, there is reduction in the CVD risk of 11% in the first year, but it rises to 36% in the 6th or subsequent years, which is very significant. Like, if a chance was 100%, we are reducing it like more than like by 36%. So the number needed to treat is really low. So we should be more proactive in starting statins early on. Indians have a 1.5 to 2-fold ACVD risk at any given combination of risk factors compared to whites, and there are recent Indian studies which have shown that people with Indian origin, Indian ethnicity are more likely to suffer from CAD and also more likely to be more sick with CAD. They have more hospitalization, more end organ damage, more complication, more chances of death, be it young or old. Higher the risk, greater the benefit for any given degree of LDL reduction. Major international guidelines currently referred to globally, the ACC, CSS, ECS guidelines as well as the NICE guidelines, which cover mostly the Northern America and the European and the UK medical practice, have all highlighted the role of statins as the first line of treatment in the optimal management of dyslipidemia. Statins remain the bedrock of lipid lowering therapy to reduce ASCVD risk, and in all guidelines, including the latest ACC guidelines of 2023 SIHD guideline, statins is the first drug to be started in any patients at risk of ASCVD, that is coronary artery disease and other ischemic stroke, or who have already suffered it. Intensive reduction in LDL cholesterol levels is recommended in patients with coronary artery disease who are regarded as being at high risk or very high risk of future atherosclerotic cardiovascular events. In clinical practice, appropriate decisions for statin type as well as statin intensity are important. However, only rosuvastatin and atorvastatin can offer both the high intensity and moderate intensity statin treatment. So we have heard about simvastatin, pravastatin and all these things. But apart from atorvastatin and rosuvastatin, none of the statins can be given in a high intensity dose. And we know that, I'm just reiterating, high intensity of atorvastatin is 40 and 80 milligram. High intensity of rosuvastatin is 20 and 40 milligram. Anything below that is moderate statin. Lipid Association of India, this is the new recommendation. Lipid Association of India recommendations for statin therapy in Indians. There is class 1A recommendation. In patients with atherosclerotic cardiovascular disease, statins should be started and with high intensity statins, and class 1B indications are there in patients with major risk factors, which includes one or more of the following, that is cholesterol more than 170 mg per dl, diabetes, tobacco use, both active and passive smokers, and systolic blood pressure of more than 140 mg. Though I would want to repeat that these recommendations are not reflected in the ACC. In ACC, we still need to categorize the patients by ASCVD risk, and if there are multiple risk factors or the patient is diabetic and above age of 40, only then we start statin. Apart from, of course, patients who have coronary artery disease, they need to be on statins. Statins for primary prevention of cardiovascular disease, or what do the updated NICE guidelines say? In people with or without type 2 diabetes, offer atorvastatin 20 for primary prevention of CVD. To people who have a 10-year Q-risk 3 score of 10% or more. All these risks are very difficult to calculate. the bottom line is important part is for people aged 85 and older, consider treatment with atorvastatin 20 milligram. This is true in ACC guidelines as well. They advise moderate intensity of statin, but there the age cutoff is 75 years. Patients more than 75 years are preferably treated with moderate intensity statin, especially but after ACVD, that is after an attack, acute heart attack or ischemic stroke, we can give high intensity statin if tolerated. Elderly people. And in people with type 1 diabetes, offer statin treatment for the primary prevention of CVD to adults with type 1 diabetes who are older than 40 years or have had diabetes for more than 10 years or have established nephropathy or have other CVD risk factors. Consider statin treatment for the primary prevention of CVD for people aged 18 to 40 years in type 1 diabetes, including those who have had diabetes for 10 years or less. This consider means it's a class 1B or class 2A indication, not a class 1 indication. When starting treatment with statin for adults with type 1 diabetes, use atorvastatin 20 mg. This is a summary. I will not go much into detail. At the end of the talk, I will summarize in which patients statins are to be started. But as you can see, age less than 80 years with Q risk, which is equivalent to HCVD risk of more than 10%, then type 2 diabetes, type 1 diabetes plus 1 CVD risk factor, CKD patients, and age more than 95 years, depending on the risk factors, we start statins. Statins for secondary prevention of cardiovascular disease, what do the updated NICE guidelines suggest? Offer atorvastatin 80 mg to people with cardiovascular disease, whatever their cholesterol level, unless the person meets the criteria of lower dose of atorvastatin. Really old people who cannot tolerate statin, only those people we can lower the dose. It is interesting to mention that all the major landmark trials that have happened, like PROVE-IT trial or TNT trial, which have happened with atorvastatin, had used atorvastatin 80 mg. We as clinicians are quite scared of starting high intensity statins, but as cardiologists, after any CAD, any proven CAD patients, we always like to start and continue the patient on high intensity statin. Only a very small fraction of patients will have muscle related complication, but I do agree that some people do have. In those cases, we can go ahead and reduce the statin as long as the cholesterol levels are acceptable. Summary of lipid loading NICE guidelines for secondary prevention. Comparison of the ESC and the ACC guidelines. Here we are mentioning 2018 guidelines of ACC, plaque regression, lumen, coronary flow and microvascular function. As we all know, statins do not only have a function of decreasing cholesterol, it also has some pleiotropic effect, anti-inflammatory effect, and many effects that help the arteries in positive remodeling and decreases the future CVD risk. And for this reason only, we give loading dose of atorvastatin when the patients comes with an ACS. Suddenly giving 80 mg of atorvastatin will not suddenly reduce the LDL, but it will do a lot of things like stabilizing the plaques, decreasing the inflammatory milieu and all these things. Short-time prescription of high-dose atorvastatin in CABG can lead to better renal function, decreasing of arrhythmias in AF. Whoever has got patients who are follow-ups of CABG, they know very well that immediately post CABG there are a much higher risk of arrhythmias, especially atrial fibrillations. Statins have been shown to reduce the incidence of such things. In the prevention of ischemic stroke, this again is a class 1 indication and we all in clinical practice give it. Here we can see there is a class 1A indication in patients with ischemic stroke with no known coronary heart disease, no major cardiac sources of embolism also, and LDL cholesterol of more than 100. Atorvastatin 80 mg daily, that is high dose atorvastatin, is indicated to reduce recurrence of stroke. And there is also 1A indication like of adding other anti-lipid therapies as well if the LDL is not controlled. Treatment of hyperlipidemia for CV risk reduction after stroke, 2022 AHA guidelines. After non-embolic stroke, the same thing again. We need to start with high intensity statin. Atorvastatin reduces first and subsequent vascular events, vascularization, any repeat stroke or TIA. Long-term administration of atorvastatin is associated with reduction in carotid artery intima media thickness in patients with ischemic stroke. As we know, IMT is has direct correlation with higher ASCVD risk, but it is done mostly for academic purposes, and really on clinical grounds we do not do routinely IMT of carotids. Atorvastatin reduces circulating SiO A12 levels in patients with carotid atherosclerotic plaque, a link with plaque inflammation. As I told, it has anti-inflammatory and pleiotropic effects as well. In addition to statins' efficacy in reducing the risk of future adverse cardiovascular events, safety concerns including statin-related adverse effects and intolerance should also be considered in real-world practice. The commonest thing is myalgia. The other things are nausea, vomiting, mild headache, and in severe cases of statin intolerance, we can have rise in muscle enzymes and all. In those cases, we have to lower the dose of statin. To control the LDL level, we have to add additional molecule like ezetimibe, which in every guideline has a class 2A or class 1B indication to add if the LDL is not controlled with adequate statin therapy. Safety outcomes associated with moderate to high intensity statin. Rosuvastatin versus atorvastatin treatment in people with CAD. Rosuvastatin treatment, this was first noted flagged in that landmark trial called Jupiter trial. We might have heard about it, that more number of new onset diabetes was seen in patients using rosuvastatin. Rosuvastatin treatment was associated with higher incidence of new onset diabetes mellitus requiring initiation of antidiabetics than atorvastatin treatment. This again, the same Lodestar trial shows the same thing, reiterates the same thing, confirms that there is more chances of developing new onset diabetes. AHS statement on drug-drug interactions. Combination therapy with statins and other CV medications is highly likely, and potentially significant drug-drug interactions must be considered in patients treated with statins. Routinely, no investigation is advised. If there is any signs of having liver damage, then we can go for LFT. These are the two commonest things involved, like which may be affected by statin, that is myalgia, rhabdomyolysis causing CPK rise, and patients who have borderline liver function or fatty liver or chronic liver disease. In them, liver function deterioration, because atorvastatin does get excreted by liver. If there is rise in liver enzymes and all, then we may need to change to the other statins or may need to change our lipid lowering therapies. But routine sending of any investigation is not recommended. With this, I'll end my talk on the lipid lowering therapy, and I'll hand over my microphone to my friend and colleague, Dr. Tutan Dash. Please welcome him for a talk on anti-diabetic management.
So, this is the topic assigned to me. Novel combination therapy to converge glucocentric, cardiocentric and renocentric management of diabetes. So I will not be making this very boring for you. I will try to simplify and will speak for a few minutes only. So I can see many of the senior physicians sitting here. So I would like to, sir, make it little bit interactive if you don't mind. All the doctors of other specialties who have multiple senior physicians and some of the super specialists also sitting here. So I would like to know, like diabetes in India, how is it different from the Western countries? Because each one of us reading the anti-diabetic guideline, ADA guideline, or all the World Federation of Diabetes, all these things, these are not Indian guidelines. So how this Indian diabetes is different from the rest of the world? What is your experience, sir? Anyone, sir, want to say something? How is it different? What is the difference between the Indian patient? Yes, sir. That obesity. Yes, very important thing. Most of the Indian patients having diabetes are either obese or they are having associated conditions like hypertension. The more association, which is not true for the Western patient. Any other thing, sir? Yeah, that is very common. Sir? Lean diabetics are also there, but as sir told, obesity is more commonly associated in Asian or Indian population compared to the Western population. And also hypertension. The association between hypertension and diabetes is more in Indian patients than Western. you'll be seeing what are there in these slides. So this is the, you can see the burden of diabetes in Indian patients, Indian population. 11.4%. That's a huge number. So basically India is nothing but the diabetic capital of India, world. And you can see the current incidence rates. Before incidence rates, what is more alarming is the prevalence of diabetes is less than the prevalence of pre-diabetes. So that means what? Pre-diabetes means the people who are likely to develop diabetes in near future, right? So that is higher. So that shows in which direction we are going. Ideally, if your diabetes is well controlled, if your disease is well controlled, and if your trend is good, if we are going in the right direction, the prevalence of pre-diabetic should be less than the diabetic. But in India, we can see it's 11% and 15%. That means the person who are likely to develop diabetes are more than the number currently we are having with diabetes. And see the incidence rate, it's 9.6. Every 100 people you are screening in your OPD or hospital for diabetes, irrespective of the age, almost 10 are having diabetes. And this incidence is estimated to rise more even in future. So this slide is very colorful, I like it. And the reason why people may not like it is, you can see here we are staying in West Bengal, which is also having a very high prevalence of diabetes. You can see the red area. So challenges in diabetic management. What are the challenges? One is poor glycemic control. Again, poor glycemic control, this is a vast topic. There are hundreds of reasons for which there can be poor glycemic control. Presence of complications and comorbidities. Hypoglycemia. One very important thing. Diabetes is, managing diabetes, you have to see the benefit. You have to control sugar in such a way that only the way it should be, or your patients are developing hypoglycemia. You are supposed to reduce the dose of the drug, but if you are not doing that, so it can go in either way. Now, why we talk about diabetes so much? What is the problem? Somewhere I read the chance of dying every person. This is one of my favorite thing. I always say this. The chance of you and me dying this year is 1%, irrespective of the disease. By chance, statistically. Once you have diabetes, irrespective of whether you have developed complication or not, you have developed heart disease or not, you have developed renal complications or not, the chance doubles. That is the problem. So many things are there. One thing is ASCVD score. It's very easy to take your mobile phone nowadays. But personally, as a cardiologist, I don't find this much useful nowadays, because I am one of the fan of statin. I believe if one drug you can give, like just like you are distributing snacks, is statin. That's why you can do wonderful things. We can imagine how much good things, how much life you are saving. Yeah, that may sound little bit awkward and unscientific, but trust me, in Indian patients, especially with diabetes, if you distribute statin, just like you distribute this albendazole, this worm medication and all in PSC, you are going to save a lot of life. What are the complications? See, the high risk obesity. What is high risk obesity? Obesity itself is a risk factor. There is something called syndrome X and syndrome Z. So these are the things you should be aware of. What are the cardiometabolic risk factors? Insulin resistance, yes, to some extent. 80 to 90% of the patient having diabetes are having insulin resistance also, and that is one of the factor for what reason our patients are not responding to our treatments. Not all the time physicians are at fault. Insulin resistance are also at fault sometimes. There are hypertension, inflammation. Yes, Dr. Moradika was beautifully describing about inflammation, lots of genes and some molecules. In layman's term, inflammation is the basic of all disease. Any chronic disease, forget about the acute disease. You have COVID, you have lots of inflammation, you have viral infection, you have lots of inflammation, you have urine infection, you have lots of inflammation in the body, forget about those. Any chronic disease is linked with inflammation. There is no disease, not a single chronic disease which is not linked with inflammation. So inflammation is one of the things. That's why many of the people, lots of studies, lots of discussions. All the physicians who are interested in guidelines and new studies, they must have come across this term, CVOT, or good for your heart or bad for your heart. That has to be proved in trial. Otherwise, you cannot market it. This advanced trial, it shows that regardless of the initial severities and HbA1c level, intensive glycemic control can consistently reduce major vascular issues, especially macroalbuminuria. Again, we are going into the diabetic kidney disease. It lower all-cause mortalities and minimize severe hypoglycemia. This is again a very interesting chart. You can see 33% decrease per 1% reduction in HbA1c. So HbA1c for many of us, it may be a simple number, but for someone it matters a lot in their life. These are some landmark trials, EPPDS advanced echo trial. No combination therapy in diabetes. Why all these discussions here? Many of the prescriptions, especially in the peripheries, your patient is presenting with a fasting blood sugar of 160, 170 for the first time. And many of us, what we are doing, metformin 500 milligram twice daily, we are leaving the patient. For that is what we are discussing today. That should never be done. It's always better to give two drug combination to start with, two different drugs, two different class of drugs which acts by different mechanism. So that, because as I told, HbA1c is just a number for us. It's a life for the patient. So they have advised many things from cardiac perspective. And again, talking a little bit about the combination therapy, there is a concept coming in recently, polypill. So that is one of the therapy, Earlier there were some studies, some opinions, some expert opinions saying that the combination therapy, if you mix 2-3 drugs in single tablet, it is not good. But that is not true for us, people like us. We are poor people, not like. It is good for only the Western people. People are educated there, people have financial stability, people are very aware, they check on time, they don't mind taking 15 tablets per day, they are good patients. But for Indians, someone who is not from that economic background or aware background, in little bit peripheral areas, if you give them 5 tablets, they will be telling, doctor, I don't want to visit you again. Because you have already given me so much medicine, I can take. This is the pill burden of the patient. So that is where this polypharmacy or polypill concept is coming. In one tablet, they can give everything. So 1 tablet per day, your half of the job is done. When they discuss, many of the physicians or even sometimes the patient ask, sir, when to start insulin? True or not? Sir, in your practice also, many of the patients coming to you and asking you when to start insulin. The answer is very subjective, right? I think for sir, senior doctor, all senior doctors sitting 5 of you, sir. I think everyone of you will differ. When to start insulin? When do you start insulin to your patient? When someone having a diabetes. There are no general consensus as such for the treating already the people who are getting treated. But yes, even if with 3 drugs, the sugar is not controlled, then definitely we have to start. There is no disagreement, right? But there will be some patients who are very smart, little bit of Google knowledge coming to you and telling, I want to start insulin straight away. What will be your response? Yes, but when to start? So they have given an arbitrary guideline, I feel they have mentioned here. Ideally, they said your HbA1c more than 10 or your sugar more than 300, you can straight away go with insulin. Okay, before that, already Dr. Manadeepa has extensively discussed about dyslipidemia. There is something called diabetic dyslipidemia. Have you heard the term diabetic dyslipidemia? So, what is the relation between diabetes and dyslipidemia? What is diabetic dyslipidemia? And what is the difference between the young people having diabetes and the older people having diabetes in terms of dyslipidemia? That we should be little more concerned. Younger people who are having diabetes are more likely to have dyslipidemia than the older people. That's been it's already found in the studies. Second thing, what is
postprandial lipid test is done.
Sir, it is not routinely done, but again, it's just like sugar, just like our sugar, the lipid, whether it's in the form of LDL or triglyceride, the amount of damage they are going to do is proportionately the longer duration of they are staying in the blood. Am I clear, sir? Be it fasting, be it is the average. It's the average. Even after eating also, we are not testing routinely. But yes, if it is high, that is not good. Same thing. It's just like sugar only. Your sugar, there are many problems with many of the medicines. You are giving the medicine. There are a lot of trials are done already. Just like BP, blood pressure. When to give the antihypertensive? What is the best time? Many of the physicians, doctors sitting here. What is the best time? When are you advising to your patient when to give the antihypertensive? What is the time? Morning 6 a.m., afternoon 12 a.m., night. Sir, any other response? What is the logic? There have been lots of controversy regarding this. Now that one of the trials has come, the time trial. They say there is no difference if you control it properly. Now how you control it properly? That's what I am taking. You have to see the half-life of the drug. You are giving a drug in the morning, the effect is going to be exhausted by evening, and even in the evening your BP will be 170, in the morning it is 110, you are happy. The patient is also happy, the doctor is also happy, after 5 months the patient is going to have a massive severe. That is the problem. So it's exactly the amount of time, it is uncontrolled. Be it blood pressure, be it lipid, be it sugar. So irrespective of whether it's pre-prandial, post-prandial, morning, fasting, it doesn't matter. It is always the case. Again, sir, there are controversies. I think, considering your age, when you have started practice, I believe you have given metoprolol tartrate to patients, right, sir? So, how many times you are giving to the patients? Twice, thrice. That is the thing. These companies nowadays, they claim with this metoprolol succinate or some of the sustained release tablets, it is going to cover whole day, but I really doubt. except for those.
নমস্কার, আমি ডক্টর মনিদীপা মজুমদার। আমার সঙ্গে আমার কলিগ এবং বন্ধু ডক্টর টুটন দাস। আমরা দুজনে একটি হার্ট রোগের চিকিৎসার মানে কার্ডিয়াক কেয়ারের একটা নতুন ক্লিনিক খুলেছি দুর্গাপুরে সিটি সেন্টারে লোকেটেড। এখানে হৃদরোগ সম্বন্ধিত সব কিছু ইনফরমেশন পাওয়া বা রোগ নির্ণয় করা থেকে রোগের চিকিৎসা অবধি সবটুকু আমরা দেখি দুজন কার্ডিওলজিস্ট মিলে। রবিবার ছাড়া বাকি প্রত্যেক দিন আমরা এই ক্লিনিকে আপনাদের টেস্ট করানো, রোগের ডিটেকশন করা থেকে শুরু করে যদি কোনো প্রসিজিয়ার বা অ্যাঞ্জিওগ্রাম, অ্যাঞ্জিওপ্লাস্টি ইত্যাদি লাগে সেটারও অ্যাডভাইস বা পরামর্শ দিয়ে থাকি।
কিভাবে বুকিং করতে হবে, মানে বুকিং কোনো কিছু?
আমাদের এখানে 2-3 জন আমাদের সহকারীরা আছেন যাদের কাছে ফোন নাম্বার আছে এবং যাদের কাছে ইমেল থাকে। হোয়াটসঅ্যাপে, ফোনে বা ইমেলে যোগাযোগ করে আপনারা অ্যাপয়েন্টমেন্ট নিতে পারেন। রবিবার ছাড়া সোমবার থেকে শনিবার অবধি সকাল এবং বিকেলে 2 সময় আমরা অ্যাপয়েন্টমেন্ট নিয়ে থাকি এবং যা দরকার যে কোনো ধরনের টেস্ট যেমন ইসিজি, ইকো, ট্রেডমিল টেস্ট বা যে কোনো ধরনের রক্ত পরীক্ষাও এই সেন্টারের থ্রুতেই হয়ে যায়।
Hello, I am Dr. Tutan.